Hi, good afternoon. My name is Raimundo Lugo, and this is my fall risk prevention and solution proposal. Introduction. Patient falls are a safety concern in my healthcare organization, especially among critically ill patients. Despite established fall prevention protocols, inconsistent implementation of safety measures, such as inactive bed alarms, poor lighting, and lack of proper patient support, continues to contribute to preventable falls. These incidents not only increase the risk of injury but also lead to longer hospital stays, higher healthcare costs, and reduced quality of care. Strengthening adherence to fall precaution protocols is important to ensure patient safety and sustain high standards of clinical practice. Root cause analysis. This RCA examined a patient fall that occurred in the ICU after a patient admitted for hypertensive emergency and hyperkalemia attempted to ambulate independently to the restroom. Even after the patient had been stabilized, fall prevention measures were not fully implemented at the time of the event. The call light was not within reach and the bed alarm was turned off, preventing staff from being alerted. This patient fell and dislodged his IV, which then resulted in bleeding. The primary contributing factors included unassisted ambulation, equipment related issues, communication gaps, and inconsistent adherence to established fall prevention protocols. While staff were trained and staffing levels were appropriate, higher patient acuity may have limited continuous monitoring. My analysis determined that the root issue was not the absence of policies, but gaps in inconsistent implementation. This explains the need for reinforced adherence to fall precautions and improved environmental safety checks. Proposed solution. A solution would be to implement a standardized fall prevention checklist in the ICU that is completed and documented at the start of every shift. This checklist would include a fall risk assessment, confirmation that the caller is within reach, activation and verification of bed alarms, and reinforcement of patient education about requesting assistance before ambulating. This will promote consistency and accountability. This proposed solution will improve patient safety by ensuring reliable and consistent implementation of evidence based fall precautions rather than relying on individual practice habits. Evidence shows that variation in the application of fall prevention strategies across hospital units reduces their overall effectiveness. This process can reduce fall risk, prevent injury, and enhance overall quality of care. Stakeholders. Bedside nurses will conduct fall risk assessments and safety checks each shift, with nurse educators providing training support and unit leaders overseeing compliance through audits and feedback. IT personnel will assist in integrating EHR prompts to reinforce proper documentation. Engaging patients and families in educational initiatives will also help ensure that their concerns and preferences inform care practices. Engaging all stakeholders in healthcare initiatives has been shown to improve communication, make interventions more relevant, and enhance health outcomes by incorporating diverse perspectives and adapting to real world conditions. The QI team will include bedside nurses, the nurse manager, a nurse educator, a quality improvement coordinator, and an IT representative. Physicians, patient care technicians, and patient family representatives can provide insights into workflow, challenges, and patient needs. Engaging these stakeholders will help ensure that fall prevention strategies are possible in daily practice and more likely to improve patient safety outcomes. Timeline for change and resources. The proposed fall prevention checklist can be implemented over approximately 4 months to ensure a structured and sustainable change process. Month 1, planning, finalizing the checklist, gaining stakeholder approval, and integrating documentation prompts into the EHR. Month 2, staff education with early feedback and workflow adjustments. Month 3, full ICU implementation with ongoing compliance, monitoring, and reinforcement education. And month 4, evaluation of fall data and refining processes to support long term sustainability. Resources required include support from bedside nurses, nurse educators, unit leadership, and IT personnel. Technologies such as EHR prompts and better alarm systems, and minimal financial investment, primarily related to staff education and workflow integration. Existing equipment, including functional bed alarms and accessible call lights, would be maintained to support consistent fall prevention practices. Measuring outcome tools. Fall incident reports will be reviewed to compare fall rates before and after implementation, helping determine if patient safety improves. Checklist compliance audits through EHR documentation will evaluate how consistently staff follow fall prevention practices. Research on fall prevention strategies emphasizes that systematic measurement of fall rates and evaluation of adherence to prevention protocols support quality improvement efforts and help identify areas needing adjustment to enhance patient safety outcomes. Together, these tools allow the quality improvement team to monitor progress, identify trends, and make adjustments to sustain safer patient care. Findings dissemination. Results from the fall prevention checklist evaluation can be communicated through structured channels for transparency, engagement, and continuous improvement. Fall rates and checklist adherence trends can be shared during staff meetings, quality improvement briefings, and shift rounds to keep bedside nurses, unit leadership, and support staff informed. Summary reports can also be provided to the Quality Improvement Committee and nurse educators to guide ongoing training and workflow enhancements. Sharing findings with all stakeholders will improve accountability, reinforce best practices, and support a patient safety environment grounded in continuous learning and improvement.